So we are on our continuation talk on dyspepsia, and today we are looking at two of the most common causes of dyspepsia, and we'll be talking about peptic ulcer disease and gastritis. So peptic ulcer is defined as a condition whereby there is a focal defect or a discontinuation of the gastrointestinal mucosa, either happening in the lower part of the esophagus, the stomach, or the duodenum. So the difference between peptic ulcer and gastritis is that in gastritis there is no mucosal erosion. It's only inflammation that is present, but the presentation can be the same. So the common causes of peptic ulcer disease, the main one is infection with Helicobacter pylori, which is a gram-negative bacteria that burrows into the stomach or duodenal mucosa and it causes ulceration. Then the other common cause is medications, especially the NSAIDs group of drugs. These include drugs like indomethacin, brufen, diclofenac, which are commonly taken by people with inflammatory diseases like osteoarthritis. Then we also have hypersecretory states, where we have some conditions that can cause an increase in secretion of gastric acid. There are some conditions that are known to influence the healing and recurrence of ulcers, especially tobacco use and also alcohol use, especially excessive consumption of alcohol. So the presentation of peptic ulcer disease, you find that in 20% of the patients, there are no symptoms. They have the disease, but there is no symptomatic presentation. Then one of the commonest symptoms is epigastric pain, which is defined as gnawing or can be burning. Then you also have abdominal fullness. We have early satiety or a feeling of early fullness after eating. Then you have nausea and vomiting. Sometimes can present with bleeding, which can be obvious, bleeding from the mouth, hematemesis, or you can have hematochezia, which would be bleeding through the rectum, or merina stools, which is tarry colored stools. Then you may also have changes in weight, depending on the presentation of the ulcer. So there is a difference between gastric ulcer and duodenal ulcers. I usually find that in duodenal ulcers, the pain occurs 1 to 3 hours after food. It is usually relieved by eating and also antacids. It might interrupt sleep, especially you find that patients will complain of being awakened in the early hours of the morning. Then there is early consistent periods of remission and recurrence. In gastric ulcers, the symptoms worsen with food and they occur within 15 to 30 minutes after eating. But there is no obvious way that you can differentiate these two conditions by symptoms. Complications include bleedings, which you can have obvious vomiting of blood. You can have merina stools. You can also have hematochezia. You can have perforation of the ulcer, whereby you have extension of the ulcer into the outside the duodenal or stomach wall, extending to the abdominal cavity, and this presents as an acute emergency. Then you can also have gastric outlet obstruction. You can have pancreatitis if there is extension of the ulcer to the pancreas, and you can also have some of the ulcers, especially gastric, transform to cancerous forms. Some of the alarm systems that might suggest gastric cancer include bleeding, progressive weight loss. You may have anemia, and the patients who are more than 45 years of age, and also in the presence of dysphagia or adenophagia, which is pain or inability to swallow. So these patients whom you see those kind of symptoms, they may need immediate esophagogastroscopy. Then for the diagnosis, there are several ways to diagnose peptic ulcer. The immediate thing when you suspect patients could be having peptic ulcer, it's always good to test these patients for H. pylori. And the H. pylori, you can do the antibody test, which is a blood test, which remained positive despite the treatment of the disease. You can also do the stool H. pylori antigen. You can also do histology from biopsy specimens after OGD. Then there's also a barium swallow, where a patient ingests some contrast sensitive media, and then pictures are taken. And then of course we have the gold standard, which is esophagogastroduodenoscopy, where you pass a tube through the mouth into the esophagus, to the stomach, to the duodenum. You can be able to see the ulcer, see its size, and also take a biopsy during this procedure. So the treatment of peptic ulcer involves, the first thing is to try to remove the causative agent. Of course, if the patient has H. pylori, you treat, and H. pylori is treated with a combination of antibiotics, which is given a course of 7 to 14 days, and it is always necessary to complete the course of treatment. Then this is followed with a course of proton pump inhibitors, which include drugs like omeprazole, esomeprazole, pantoprazole, rabeprazole, and then also avoidance of NSAIDs, especially when it is avoidable. For patients who really need chronic use of NSAIDs, especially for conditions like osteoarthritis, then sometimes it's also good to give them concurrently with proton pump inhibitors. Then it's always very advisable to stop smoking, especially for those who are smokers, because cigarette smoking has been shown to be one of the major causes of recurrence of peptic ulcer disease, and it also enhances recurrence of peptic ulcer disease. After the treatment, patients are followed up in 6 to 8 weeks. For duodenal ulcers, this you expect to have healed, but for gastric ulcers, you may expect a prolongation of the symptoms for up to 3 months, but we may need to do serial esophagogastroduodenoscopy to monitor the healing of the ulcer. Thank you very much. Our next series of talk will be gastric reflux disease.